Guys for joining us today for our ECHO presentation. Our ECHO is centered on hypertension and cardiovascular disease for those who are new to our ECHO series. And today we have a full agenda and we're really excited about our case review, which will be presented by a very important partner in the work that we're doing in our regional collaborative. So we'll start off with introductions. We will go into our didactic presenter presentation, which will be presented by our own Sylvia Coleman. And then we will have our case review, and then we'll follow up with some discussion and housekeeping items. I want to first take the opportunity to introduce our ECHO series subject matter experts, and I'll start with whoever I see first. So in my screen, I see Dr. Bretler. If you can introduce yourself to our participants.
Sure. Good morning, good afternoon, everyone. Jeff Bretler, I'm an internist from Los Angeles. I help co-lead the Kaiser Permanente Southern California Hypertension Program and also serve as a consultant for the Pan American Health Organization in the area of hypertension. Nice to be here.
Thank you. And Emily Ridley, please.
Hi, good afternoon, good morning. I'm Emily Ridley. I'm a clinical pharmacist based off an internal medicine residency clinic within Prisma Health in Columbia, South Carolina, where we serve primarily a low-income, urban and rural population of patients. I've worked with our health system and quality improvement efforts regarding hypertension control, and on the Constellation Regional Collaborative Advisory Board as well.
Great, thank you. Dr. DePetty.
Well, good morning, everybody. My name is Don DePetty. I'm an internist, similar to Dr. Bretler. I did some post-residency training in hypertension in Boston. I serve on the Constellation Quality Health Board of Directors, as well as also, as Jeff, I'm an advisor to the Pan American Health Organization and the WHO for the Global Hearts Initiative and the Hearts in the Americas Initiative. And it's just a pleasure to be part of the team.
Thank you so much, Dr. DePetty, and welcome to our participants. Please go ahead and share your name, your employer, organization, your position, and your credentials in the chat. We would love to continue to share information along the way, so please go ahead and put that information in the chat. We have Sydney Fleming, who's from our team, who's going to be monitoring our chat. All right, so we are really excited to introduce our presenter today. Some of you already know her. She is a strategist on the Constellation Regional Collaborative. So she has been instrumental in this work, but she's also the president and CEO of Sylvia Coleman and Associates. Sylvia has over 30 years of experience in community and public health. Her work both focuses on integrating health and human services to improve whole person or person-centered care and population health outcomes. She also serves as a fellow on the American Heart Association. She's a nurse researcher, a health policy advisor, and a community health worker ally. She serves on state and national committees, including the Partnership to Align Social Care, which has been instrumental in the work that she's been able to contribute to our program. And a lot of what she'll be sharing today will be from her partnership with the Partnership to Align Social Care. So welcome, Sylvia. I will pause here to hand it over to you, and we're really looking forward to your presentation.
Thank you, Maxine. We could have, I didn't know Maxine was going to tell you that much about me, but thank you, Maxine. I'm thrilled to be here with you this afternoon, and Erica, and some members of the Novant team. I see Kim, and we have Jordan, the public health intern, with us. and maybe others will be able to pop in. But anyway, we're really excited to just begin. It's the tip of the iceberg to begin exploring the new Medicare billing codes for reimbursing auxiliary personnel, including community health workers. And I see Rebecca shilling on, so hopefully this will be music to your ears, Rebecca. I will just preface that we don't have a lot of time today. It is the tip of the iceberg, but just to let you know that Constellations Regional Collaborative is building out a whole training program around this that will be rolling out this summer. So we're whetting your appetite for more today. Next slide, please. We're going to spend the first 20-25 minutes this afternoon just talking about the new codes that are related to addressing health-related social needs. And then what we're going to do at the end is have some discussion that hopefully motivates all of us, whether you're in healthcare or whether you're in human services, whether you work for a healthcare provider or practitioner, or whether you're in a community care hub or community-based organization, to motivate all of us to learn more about these codes. Community health integration, principal illness navigation, and principal illness navigation peer support, so that we can all be better reimbursed for the services and improve outcomes for our high needs patients. Next slide, please. So when did this all come about? We say the new Medicare billing codes, and they are new because they are the first. This is really a landmark final rule that initially went into effect January 1st of 2024, when CMS updated the physician fee schedule for the first time ever to include language that reimburses for services never reimbursed for before, to address health-related social needs for patients that have clinical diagnoses that practitioners are having difficulty diagnosing and or treating. The rule was updated effective January 1, 2025. And the rates were reduced slightly from what they were starting last April. In April, the Biden administration bumped the rates up just a hair. But when they came back out and were approved for January 1, 2025, they went back down to the original January 1, 2024 rates. And we'll talk about those in just a little bit. But the language that's included, again, for the first time ever, supports partnerships with community-based organizations and community care hubs that all work collaboratively to improve patient care. And that's music to, I think, all of our ears. Next slide, please. I want to walk you through, you can see listed here some of those health-related social needs services that are provided under community health integration, and they are to address those non-medical factors that are affecting a person's health. And I want to just kind of walk you through the trajectory of when a referral is made, and then we'll get into some of the ins and outs of what's required and the reimbursement rates. But just so you have a little bit of an understanding of what happens when a referral is made for a patient to auxiliary staff. And auxiliary staff, you know, sometimes we think about in what we're doing with the regional collaborative, we tend to think about community health workers because they're at the core of the work that we're doing with our community care hub and otherwise. But CMS recognizes other disciplines in auxiliary care, and those can be social workers, they can be nurses, they can be registered dietitians, they can be health coaches, and sometimes we call them other things too. So we're talking about community health workers and all of these other auxiliary staff. But once they receive a referral, the first thing that they're going to do is make a phone call to that patient and explain the service. It's just like any other service. Because we get a referral, it doesn't mean that the patient and their family have to accept it. So they explain the service, and we'll talk a little bit about the co-payment here momentarily. And if at all possible, schedule a home visit, because remember, these are high needs patients, and it's really important to get into the home and see what's actually going on there. So schedule a home visit. They may even schedule a visit to meet the patient at the referring provider's office, because sometimes it's really important for everyone to hear the same thing together. And when Erica presents her case study, she'll have a really good example of how things can get very confusing quickly when a patient is seeing multiple providers. And then just to learn what the patient understands about their diagnosis or diagnoses, their medications. Do they even have their medications? Do they know how to take them? Maybe assist them with filling out medication access paperwork, and making other referrals, and not just making referrals, but making sure the loops are closed, that someone actually contacted the patient, and that that referral is making progress through the system. And our health system is really incredibly hard. Even those of us in healthcare, I find our system hard to navigate. So we want to make sure that we're helping that patient and their family navigate the system. And last but not least, giving them hope, providing that social and emotional support so that they have the hope that they need. That if they follow all of these hard things that we ask them to do, that they can and most likely will get better. Next slide, please. There are some requirements. I mentioned that when that initial call is made, that we have to get consent. It may be verbal. It can be verbal or in writing if we're face-to-face, but it must be documented in the electronic health record. And there must be screening for at least one health-related social need. And we'll talk about how that's done here momentarily. And then a plan has to be created. There has to be a plan of care in the medical record that we update along the way as we learn about more needs, because usually if there's a referral for one health-related social need, once the auxiliary staff member gets out there, others are identified. And every time something else is identified, it must be relayed to the practitioner and put in this plan of care. And I put a key tip here, and I saw Suzanne come on from I believe Suzanne's on now, the community paramedic. And we've had some conversation around this about how, we in health and human services, we chose these professions because we want to help people and we want to do everything that we can. And that's fine and good. But to get paid by Medicare for community health integration services, they must be have a direct link to a health outcome that will be achieved or better achieved if that need or needs is addressed. Next slide, please. So again, prerequisite is that we have to have an initial visit, and it does have to be done by a billing provider or practitioner. And we've learned through the Partnership to Align Social Care, we've learned language over the past month that by Medicare, a provider is seen to be a hospital or a health system. A practitioner is seen to be a physician, a nurse practitioner, a physician assistant, a clinical nurse specialist, a clinical psychologist. Those are practitioners who may be working in a provider environment. So you'll hear me interchanging a little bit, but that's what we're talking about. And during that initial visit, that billing provider who's going to follow this patient throughout any of the community health integration services develops that plan of care and makes a referral to the auxiliary personnel, either through a community-based organization or through a community care hub. Next slide, please. And so this initiating visit by the provider or practitioner can be done during an annual wellness visit when they're seeing the patient. Maybe it's been 6 months. You know, if they're a Medicare patient, they should be seen at least every 6 months. So maybe it's 6 months and the practitioner just can't quite put their finger on what's going on with the patient. They have an idea, but they're not quite sure how to diagnose, or if there's a new diagnosis, how to treat, because they are suspicious that there might be some non-medical factors that are keeping the patient from moving forward since their previous visit. Or that patient may be in for a follow-up visit. It can be an evaluation and management session where the patient is no better than the last time, or they may have pre-existing symptoms that are worsening and they have some concerns that they're non-medical barriers. The patient may or may not tell them what it is, but they can, have to have a good idea because they have to document in the medical record, in that plan of care, that there is at least one health-related social needs before they can refer and bill for community health integration services. And one of the key things here, and why this is all going to sound simple to you, but I will say one of the reasons why, even nationally, people who have been studying this for over a year now are still getting all of their ducks in a row to be able to bill is because of documentation. You all know that we in healthcare are very private and secure, and that's for all good reason. Let's say Epic, for example, that the Novant Health team uses. It is rare that a health system or a hospital allows those outside of its system to have access. And when they do, it's usually read only. But remember, we have to have this bidirectional communication channel. So figuring that out is one of the things that can take some time, and that documentation ultimately rests with the provider or the practitioner office. So this is one of the things that can take some time to get into place. Next slide. These are the codes, and what do we mean by HCPCS? That's the coding system that's used by Medicare, Medicaid, and private insurance. It actually stands for Healthcare Common Procedure Coding System, and it's for all of those products and services and supplies that are not included in traditional CPT codes. But anyway, the numbers on those codes for the first 60 minutes is G0019. And this first 60 minutes does not have to be all at one time. Part of that time can be in that practitioner's office. And then once the referral's made, the balance of that first 60 minutes can be by the auxiliary staff following up with the patient. And you can see what the national, this is national because it's different for every state, but this is the national average payment rate. Just under $80 at $77.96. And for each additional minutes, 30-minute increments, and they don't have to be all in 30 minutes. It can be 10, 10, and 10 minutes where you call the patient, then you make a referral, then you follow up on the referral. It's really important to document all start and stop times because there's no limit to the number of additional 30-minute billing sessions in a calendar month, and then you start over for the next month. And for each additional 30 minutes, it's $48.52. And for providers and practitioners, they may not think that's a whole lot of money. But to community-based organizations that are working hard to sustain their community health workers, it can make all the difference in the world in sustaining. And Erica, I see you have your hand up.
Well, when you're done with the slide, you said that the 60 minutes didn't have to be all at once. So this scenario could happen. I just want to make sure you confirm this. They could have a 30-minute visit with the provider where they initiate the plan, the care plan, and then the community paramedic goes and sees them for another 25 minutes. And then the community health worker goes out for another 15 minutes, and then that 60 minutes could be billed.
Yeah, and actually you're over at that point. I think if I did the math, you're over your 60 minutes. So
By
then
like
that
5.
Yeah, by like 5 or 10 minutes. So that's why it's really important for each discipline to make sure that they're documenting their start and stop times, because now you're into that additional 30 minutes
So
that
then
you
they
can.
see him an additional twice and 2 more times that month, and they see him for another total of 35 more minutes. So then we're at another 30 plus, and it just keeps running over, right?
And then it keeps running until the end of the month, and then you start over. The next month you
Okay.
have to have 60 minutes, because you see it's a little bit more lucrative to have each additional 30 minutes, but they make you have that first 60 minutes first. That's a little bit less rate if you break it down. Does that help, Erica? Does that make sense?
Yeah, I mean, I think that's great to know that you can split it up between people,
Yeah,
you
yeah,
know?
for a different auxiliary staff too. It's important
Okay.
for all of us to keep up with it, because remember, in auxiliary staff, that can even be nursing time, who's addressing that specific health-related social need that's in the plan of care or needs. Next slide, please.
Thanks,
And
Sylvia.
you guys jump in. We don't have to wait until the end, just like Erica did, if you have a burning question. Let's talk just briefly about principal illness navigation services. And those services are for patients that have been diagnosed to have a serious condition or diagnosis that's expected to last at least 3 months. And our patients that have uncontrolled hypertension, and that's our primary population that we're working in the Constellation Regional Collaborative to address. If they have had uncontrolled hypertension for a while, and I'm just going to give you a handful of examples here, maybe it has led to a heart attack. We hope not, but if it has, they're going to need to be followed for more than 3 months. Maybe they have the beginnings of heart failure, or maybe they've had uncontrolled hypertension to the point they're having the beginnings of some renal disease. All of these patients could benefit from principal illness navigation services because they're at high risk of being in and out of the ED, being admitted or readmitted to the hospital, nursing home placement. Maybe their caregiver is getting to the point where they say, if we don't turn this around and make things better, we're going to have to look at placement. We want to keep patients at home for as long as possible. A sudden worsening of symptoms that they already had, and they're getting worse, and we're afraid that physically and or mentally they're going to decline. And just like for community health integration services, there has to be that initial visit with the provider that's going to follow them through the principal illness navigation care management services and be doing all of the communications with the auxiliary staff and doing the billing. And again, principal illness navigation services can go on month to month to month for as long as warranted and clearly documented in the medical record. And after 1 year, what's required is another initial visit to continue services, because some of these patients, once we get them on service, it takes a long time to address all of their multiple needs. Next slide, please. Here are the billing codes for PIN G0023 for that first 60 minutes. And for each additional 30 minutes, G0024. And just like for community health integration, all of the things that I said before, keeping up with all of the minutes, who did them, what they were for, documenting those, and for the auxiliary staff, getting all of that documentation. However, you've worked it out with your provider or practitioner, getting it into their system for billing purposes.
Maxine, I think that Sylvia froze.
Okay, thank you. I wasn't sure if it was just me. It looks like she's trying to get back in, so just bear with us a few minutes. All right, I think what we can do is we can troubleshoot Sylvia coming back in, but I would love for us to jump to the case review. Erica, let us know if you are ready. And then when Sylvia comes on, we can continue the discussion from there.
Sure. Yeah, we
Okay.
can start the case review.
Okay, great. Thank you.
And I'm very informal, so please just interrupt if you've got any questions or comments. Some of the people that are on here right now, one of the ladies that's on here, and I think she's still here, is Suzanne. Suzanne is the community paramedic that we've been working with while we've been involved with Constellation. And so she actually was the community paramedic that followed this gentleman. And we thought it was a good case because things don't always turn out exactly as you would like them to. It's not always ideal. Things can be a lot more complex than they seem. So we called this guy that she was following Strawberry Soda Guy, and it'll make a little bit more sense to you in the end. But he was a 62-year-old non-Hispanic male, history of high blood pressure. He had stage 4 kidney disease, not on dialysis, but getting close, anemia from kidney disease, and a thyroid nodule. So, I mean, his cholesterol was good. His A1C was good. Sylvia's back. Do you want me to halt?
It's up to you. You can continue. Sorry, guys. I don't know. I had a large, like, sonic boom that shook my house.
Ooh.
And I've never had that happen during a presentation before. But it's up to you, Erica, since you've started, if you want to go ahead, and then I can come back and finish up, and then we can discuss it all at one time since you've started. My apologies. That was a little scary. A lot
Glad you're
scary.
okay.
Yeah, I'm okay, and my house is still standing, and I've got internet again, so we're good.
Okay. Yeah, we can do that. Our presentations kind of go together, so I think that works. So Strawberry Soda Guy came into the emergency room. He had left-sided numbness, weakness, and some difficulty speaking. They did a CT scan. It showed some intracranial stenosis, and we gave him TNK, which is the clot busting medicine. So this was an ischemic stroke we were looking at. He got TNK, and the MRI ended up showing a pontine infarct. Later, they did an angiogram, which showed the same intracranial stenosis. It was greater than 80%, and they decided to treat that medically. They weren't going to do any intervention for this. So they had him on aspirin and Plavix for 90 days. And this was back in September. He was sent home with a blood pressure goal of 130/80, which is our standard for what we send most of our stroke patients home, with a long-term goal, knowing that he wasn't quite there yet, but that's where we wanted him. And at the time, his BMI was 38, so he was quite overweight. He was discharged. He actually went to acute rehab hospital and was seen there for a bit. I don't know who, thank you. These were the medications he went home on. He was on some medications for his blood pressure, Norvasc and Coreg and hydralazine. He was on Lasix for kidneys. He was on Lipitor just because he had the ischemic stroke, but I believe his LDL was like 87. He was on Protonix. They had him on bicarb for his kidneys, iron for his kidneys, and then aspirin and Plavix. And that was for 90 days, the aspirin and Plavix. And then this is kind of like where we went with him. He was a good person for Suzanne to follow. So we had Suzanne follow him. And I just wanted to make a point on this slide as far as how many people actually touched this patient. So this wasn't a patient that was discharged home and kind of lost in the system. He was followed by multiple people. I don't know what everybody's position here is, but we do a TCM call and then TCM visit. So that's the transitional care management. And the goal for that is to do a call within 2 days by a nurse and then have them seen in the clinic within 14 days. So he did have a call by the nurse twice. Suzanne went and saw him 10 times. And this is in a 3-month period. September, October, November, December, January. I'm a little over 3 months, 4 months. He was seen by the community health worker 3 times. I called him once. The neuro clinic saw him twice. He went to outpatient rehab and had all 3 disciplines, and they saw him 13 times. He was seen by renal twice, and then his PCP saw him 3 times in this period. And one of the things that we do, and we've started using since we started with Constellation, is we partnered with our community paramedics and we're using a home monitoring system. So this system allows the patient to take their blood pressure, pulse ox, weight, if applicable, at home. And it transmits the information to the person following them, and they get a daily reading log. Strawberry soda did not have a ton of consistency, and so he wasn't always in the same place all the time. Sometimes he would be home, sometimes he went and stayed with his mom. So he wasn't super compliant in checking his blood pressure daily, but here's the log. He was kind of up and down, up and down, up and down the whole time when he took it. We can go to the next, please. Thank you. And then I just kind of wanted to go through what happened in all of these visits. You know, originally he left with the timeline of a goal, or I'm sorry, the goal of his blood pressure being 130/80. When he was discharged from acute rehab, they had the transitional care management call. They scheduled the appointment with his primary for the TCM visit. At that time, he was using his walker. He didn't have home health services. And then I'm trying to look, at one point we set those up for him. He didn't, I think the home health hadn't been out to see him yet. And then I called him a couple weeks later. He was checking his blood pressure. He wasn't able to give me the numbers, but he was saying that he was doing it. He didn't start his therapy because they didn't accept his insurance. And so this was the point where I was like, all right, let's see if we can get somebody out there to help him. So Suzanne was ordered. And then he didn't want me to give him a list of people to go or call anybody for therapy. He wanted to talk about that with the primary care. And he went to the primary care provider the next day. And on the next appointment, or his first appointment with the primary care, they changed his blood pressure goal to a 140/90. Then he was seen again by the community paramedic. He didn't have any social determinants of health needs. His LDL was fine. His A1C was within parameters. He wasn't a smoker. His BMI was 38, and he had hypertension. So Suzanne kind of decided she was going to focus on his diet and blood pressure management. Then he started therapy at our rehab facility, all 3 disciplines. He was seen again by the community paramedic, and at that time he'd run out of Lipitor, so she assisted him to getting another script for that. Then was seen by renal, and they ordered a low sodium diet and changed his blood pressure goal once again to 140/80 now. And you kind of can see what's happening here, right? It's like, all right, he didn't have any needs, but then he ran out of his Lipitor. His blood pressure goal was 130/80, and then it was changed to 10 points higher. And then it was changed again. When he went to see his primary, his blood pressure was stated that it was within goal, and it dropped 20 points from originally seeing him. So they were happy with it, although his readings were kind of running up and down. They didn't make any changes and were happy with where he was. Suzanne saw him again in November and gave him the printout because he was running high, and had him talk to his primary care. And at this point, she's like, all right, let's do a food journal, because he was drinking strawberry soda in the morning and come find out. And his diet just really wasn't great. And it's hard, right? Because he has kidney disease. So the diet for kidney disease is a little bit different than the diet that you would follow for diabetes or high blood pressure. And so there's a lot going into that. So Suzanne's really good at going over diet restrictions and motivating people to be active and getting their diet in control and seeing what makes sense for the way they live. He unfortunately didn't really have a lot of control over what he was eating. His family cooked for him, and he just ate what was served. Which is what we teach all of our kids, right? You just eat what you're given. And so he really didn't have much choice in this, but he did have a choice on his strawberry soda. So then he went to see neurology again, and we're like, nope, we want his blood pressure low. We don't want his blood pressure so high. So back down to a goal of 130/80. And it's kind of like back and forth, back and forth. In the end, on the 14th of January, he'd lost some weight. He was trying to monitor his diet as best as he could. He had a blood pressure cuff that he could continue doing at home. There really wasn't anything more Suzanne could do for him. She'd armed him with everything he needed. He just needed to continue. And so the last thing she did was hook him back up with community health workers, because come find out, he had this electric bill that needed to be paid. And so the community health worker went back out to kind of see if she could help him with that a little bit. And we signed off. So that was in January. And then we can go to the next slide. But 10 days later, back in the hospital, unfortunately, and Suzanne and I had just talked about it. We were like, all right, he's got a blood pressure cuff at home. He's got her phone number. He can do all the things independently, and he just needs to continue on. And then 10 days later, I texted her and I was like, oh gosh. So he came back in. They weren't sure if this was like a recrudescence or another stroke. He was admitted. He did end up having another stroke. While he was here, his blood pressure was running great. It was in the 130s. But while he was here, they thought, all right, he's got this intracranial stenosis. We really can't do anything about it. We've got to push past it. And so they increased his goal, his blood pressure goal. And so he ended up going home. They decreased his Coreg from 25 BID to 12.5. They stopped his hydralazine, and they also changed his Plavix to Brilinta. So, I mean, that's huge changes, right? To still get at the same blood pressure goal of 140/90. Now, we were worried his blood pressure was too high, but now in all actuality, we need it higher because of the stenosis that he's got. And so it just can be so confusing, and it's not always as simple as it seems. You know, could it have been the Plavix? Now it's changed to Brilinta. Hopefully that'll help. But Brilinta is also expensive, you know, and so we've got to make sure that they can afford that. The good news is, what a fantastic job. Not drinking strawberry soda as far as we know, and his BMI went from 38 to 33. I wrote down today, because I didn't really know what the calculation was in order for your BMI to drop, you know, since it's related to your height and stuff. So he went from 277 to 243 pounds. So he lost 30 pounds, 35 pounds in the time Suzanne was seeing him. So I think that's amazing. You know, she was able to really help him with this diet and focus on what he needed to focus on, and was able to have some success with that. So I think she should really feel good about the work she did with him. and the work he did for himself. So he was discharged back home. He went to the primary care on the 29th, so just 5 days later, and his blood pressure was 120/85. I mean, how does this happen, right? It's like so high, and then he goes to his primary care, it's 120/85. They knew of his med changes, they knew of his goal changes, and when he went to see the neurology office, we discussed Wegovy and, continued weight loss. But his insurance wouldn't cover the Wegovy, unfortunately. So he's just got to keep on doing what he's doing. Of note, what is that, 2-3 weeks later, when he went to the neurology office, his blood pressure was 151/81. And I think that's kind of how this is for a lot of people. They're up, down. It's really hard to keep them at a steady level. Let's see. So that's kind of what I've got. Although this is maybe a success story, in a sense it is, it's actually the reality of what happens every day and what we're trying to combat with, arming people with every resource they can have by having community paramedics, by having the community health workers, dietitians. That's huge, that they can be, that they can have some coverage as far as billing, because we have a dietitian that sees a lot of people over the phone. He does a virtual visit. So that might be something that we can think about. One of the previous slides where I had everything listed out, I just put a little $sign next to things that I thought, well, maybe this would have been a way that we could have billed, because I don't believe we were billing for these types of visits. So, I mean, in the future, I think that's just something we need to bring back to our team and see how we can best take advantage of the new billing codes and give people credit where they deserve to get it. That's all I've got. Does anybody have questions?
I have a quick comment. Excuse me. Right before I was boomed, I was talking about principal illness navigation, as I recall. And I think, Eric and Suzanne and I were talking about this yesterday in preparation for today. I think that this would have been a really good case. And I know that you're working on this within your Novant Health system of how to implement these new billing codes. But this one would have been a really good one for principal illness navigation, because you've got this man who's got multiple diagnoses that are going to last for a long time, certainly more than 3 months, and put him at high risk for being rehospitalized, which he was within 10 days. And so to get reimbursed for all of the work that Suzanne and the community health worker and others who are surrounding this patient would have been able to bill for this. Because it is, as you said, he goes to primary care, and then he goes to the neurologist, then he goes to the nephrologist, and he's getting mixed messages at each of those. Suzanne said it beautifully yesterday. If she wasn't driving, she could come on and say it herself. But she said it beautifully yesterday that each practitioner is really looking at the patient as to what they need their outcomes that they're addressing to be, versus looking globally. And that's why it's so important to have these auxiliary staff that are working with these high needs individuals to figure out and then help the patient figure out what it is that they're supposed to do, because it's confusing. It's very confusing. It's very complex. And so thankfully, for the first time ever, we have these new codes that can help us get reimbursed for all of this hard work that we're doing to surround the patients and improve their outcomes. And that right there is just what, for providers and practitioners that would rather not fool with these new billing codes, because we do hear that, it's worth it. It's worth it to have auxiliary staff. The Novant Health system has community paramedics and community health workers within their system, but most systems don't.
Yeah, I mean, I think that's a good point. I was just thinking that, like, hopefully with the codes, this just becomes more common and more common that we're using it, and it's just the norm anymore because it matters. It really does. I mean, having somebody come into the place where you live and actually seeing what your competing priorities are or what you actually very well may need, because people don't always say what they need, right? You've kind of got to observe that. You've got to really dig and make a relationship. Maybe they don't even know what they need.
And getting to the root cause, helping them figure out what is the root cause, because that's what you have to get to, is not what's on the surface, but what is the root cause of these non-medical factors. And like you said, sometimes they don't know, and they're so overwhelmed, and their caregiver and family is overwhelmed with all the competing priorities, sometimes multi-generations living in the same home and just trying to, deal with life. So that I want to be quiet and let others comment and ask questions. And if we have any time, we can go over that one last billing code.
Erica, I have a couple medical questions. Number one, did his neurologic symptoms completely resolve after these 2 episodes, or did he have some, chronic disability that was longer standing?
He had a chronic disability. Well, he did not completely resolve after the first stroke.
Okay.
So after the first stroke, he had some continued weakness, right-sided weakness, and he was using a walker or a cane. And I think just some dysarthria because he was going to rehab. He went to acute rehab. But then after the second stroke, he returned to the baseline of after his first stroke.
Got it. Because that would have, the reason I asked was, and obviously everybody, you all know this, is that there would be a difference if he completely resolved versus he had chronic, disability, et cetera. And that makes total sense. And I'm sorry for him, but happy that he resolved the second one. That was just unbelievable.
Yeah.
Amazing.
I'm
Probably because of the
happy he
watershed.
came, right? Like,
Yeah. Amazing. Second question is, does Novant Health or maybe even internal medicine within there or nephrology, do they use any standardized treatment protocols or algorithms for hypertension? Not just for him, for this individual, but for, the vast majority of hypertensive individual that you all see, like we do here in Prisma?
I'm sure that there are. I can't really speak to that as far as what it is.
Sure.
I know nephrology in their note, they'd referenced a study as to why they wanted his blood pressure within a certain parameter.
Got it.
We usually use the goal of 130/80. We will start them on, we being neurology, start them on medications to control their blood pressure if need be, but that's usually left to primary care. And I don't know enough about what they're doing as far as if they have a standing protocol or not, or if it goes doctor by doctor.
Sure, totally appropriate. Do we also know? Did we know his adherence to the medications? Because maybe the fluctuations. He's on multiple short acting, at least some short acting antihypertensive agents, and I was wondering if his adherence was good, or whatever good is, et cetera. That was maybe a factor as well. I don't know. Anyway, that's it.
Yeah, no, I mean, I think he was, when Suzanne saw him, she went through all of his medications. I think he was kind of back and forth from home to home, just as far as like who was helping him at the time. And so I'm sure perhaps the time of day, maybe with like TID hydralazine 3 times a day, that can be hard, to stay on track with that. And so I believe that he was not as compliant as we would have liked, but I don't think he didn't just stop taking his medications.
Thanks, Erica. A very, very difficult patient, no matter what. I don't care where you are or who you are. That is he's a very, very difficult patient, and kudos to the team that followed him so closely.
Thanks. I appreciate that.
I see Emily is putting something in the chat about having community paramedics in your system. Emily, if there's anything you want to come off and ask or say, we welcome that.
That's just been very helpful. getting some insight into things that, you wish you could be a fly on the wall sometimes. And they really provide that insight into what's going on, and also that monitoring and education that Erica had mentioned had been provided just is really invaluable. So
the beauty of team-based care, right? Including the pharmacist. Emily represents our pharmacists. But, that's one of the things that we've been talking about in our Novant Health Learning Collaborative meetings is, wouldn't it be great? They have a mobile unit of being able to add a community pharmacist eventually to the mobile unit to go out at least periodically into some of these high needs areas to help patients understand their medications and how they work synergistically and how they make conflict. It's just someone looking at that. And primary care needs to be that point where you can look at who's ordering what, but the pharmacist with the medications is just critical to see what, and then we have situations where patient doesn't get all their medications from the same place for various reasons. But I think this is a great case study for us to look at what uncontrolled hypertension, what it can lead to, but how difficult it is to manage and how important it is to surround that patient with team-based care. Everyone plays a role. Were you saying something, Erica, or are you talking to Jordan?
I was talking to Jordan.
Okay. Anything else for Erica? We have about 5 minutes. I think we can get through the last couple of slides since peer support is different. Anything else for Erica? Thank you, the Novant Health team. They are shining stars. I just applaud them for everything they do every day. You just heard an example of the complex patients they work with and on behalf of. So thank you for sharing today, and we invite you back to share other case studies in the future too. But right quick, with Principal Illness Navigation Peer Support, this is different because these are services to work with patients that have a behavioral health need or substance use disorder. And we say that they're by peer support workers, but peer support workers come from various disciplines too, and oftentimes they are community health workers. And the services that are provided under peer support, they vary, and they vary depending on the diagnosis. You may get a referral on a patient that has depression or anxiety, or maybe schizophrenic, or maybe they have an addiction disorder. They're addicted to cocaine or heroin. So those plans of care are going to be different depending on what the actual diagnosis and the severity. So the scope of services will be different. But once again, the patient has to have an initial assessment by the practitioner that's going to be following them and going to be doing the billing on the PIN peer support. Same thing, helping that patient understand their diagnosis and navigate through the healthcare system, help them to not only receive referrals that have been made, but to assess the need for other referrals. And once again, this can be on an ongoing basis. And at the end of a year, another initial visit can be done to continue these services. Next slide, please. These are the billing codes, G0140 for the first 60 minutes and G0146 for each additional 30 minutes. Next slide, please. Documentation, similar for what we would document for anything that's health related. But in addition to the name, the patient name and date of service, this is where I mentioned earlier, it is critical, and Erica asked questions and gave good examples of why it's important to not only include start times. We're used to including start times, but we don't always put stop times. And we need to make sure that stop times are being included so we keep up with every 10, 15, 20 minutes, so that we add up to our first 60 minutes, our initial 60 minutes, and each additional 30 minutes. And the documentation must address the needs that are in that plan of care. The initial need and any other needs that are identified need to be relayed to the practitioner, to the provider, so that it is added to the plan of care. All interventions, any next steps, and then signature and date. And I'm going to stress here that it's really important to make sure that the documentation is sent over to the billing provider quickly, because, for example, like today's February 27th, tomorrow's the last day of the month. Your billing provider may have a system in place to where at the first of the month, those bills are dropped. And if you don't turn in your billing until Monday, you've missed the boat. The provider nor the auxiliary personnel organization are going to get their piece of the pie. Next slide. Let's actually skip to, well, let me just highlight the very first, go back one, Kathleen. Let me just quickly say that there is cost sharing. This is part B. There's cost sharing, but please don't let that discourage you, because with the cost sharing, 90 to 95% of our Medicare patients either have Medicare Medigap policies or they're dually eligible for Medicare and Medicaid. So that 20% cost sharing would be covered. Next, please. This slide is just to bring home the importance of us all working together to learn more about these codes, whether we're on the healthcare side, whether we're on the community-based side, that we're all coming together to learn more so that we take advantage of these new codes. Next, the next few slides are just some resources that you can even sign up to get emails from CMS. And then we're going to leave you with some resources that Kathleen will share out with you after today's learning session. Thank you, guys. Apologies again for the boom and the disconnect, but thank you for jumping in on the case study too.
Thank you so much, Sylvia, and thank you, Erica. This was a really informative presentation. Great discussion by our participants and SMEs. And again, thank you, Erica, and to your team. Novant Health has been an incredible collaborator in the work that we're doing, and we're excited to see them continue this work in the years to come. A reminder for our case reviews, if you have any case reviews that you would like to submit, we are sharing the link right here. Our case review presenters do get compensated, and we do like for our case to coincide with our presentation, like it was lovely. It was done lovely today with correlating with Sylvia's presentation. We want to also remind you of our next session will be Thursday, March 27th. We are going to have a presentation from Mina on their Dollar Tree menu presentation that they did with their college. And we're looking for case reviews for this, particularly focusing on food insecurity. We are really excited about this. The slides for this presentation is on our Echo Hub, as well as the video will be on our YouTube channel. We'll go ahead and email it out so that you can get those links easily accessible from Sylvia's presentation. And then to earn the continued education credit, please go ahead and submit our post-ECHO survey. We'll love to hear from you, see what we did great, what we can improve. And thank you all for joining us today. Thank you to our presenters and our case reviews and our SMEs. You guys all have a wonderful day.